Hi, this is Ellie Fishman, and welcome to Facebook Live. It's Thursday, it's 10 a.m. I do apologize for not doing it 12 noon, which I always do, but believe it or not, I have to catch a flight at 12:30. So I'm going up to Nantucket. I won't give you any more details than that, but I'd like to welcome everybody. Now, today, for many of you, it's July 1st. Well, for everybody, it's July 1st. For some of you, that means more than for others. For some of you, you're probably off today because it's the start of a long weekend. July 4th is on Sunday, so people in the US get off on Monday. So it's a long weekend. But for many of us who are in academics, July 1st is the day our new fellows start. So in about 1 hour, I have to give the introduction to our new fellows. And our old fellows left yesterday. Many of them left a couple weeks ago, or a week ago, or days ago. But yesterday was their final day. So I want to say that we had a wonderful group of fellows who survived through a very difficult year, and I want to again thank all of them for just an incredible job, and I wish them only the greatest of success in their future. Now, our new fellows, we actually are back in the reading room. Everybody, body imaging, CT, MR, ultrasound, plain film, fluoro, have been there all the time, but now we're back. We're still wearing masks. I predict we'll be wearing masks sometime into 2022, if not all of 2022, but surely at least through the first quarter, maybe the first half of 2022. But we look forward to a wonderful group of fellows, and I'll be meeting them in 58 minutes, okay? It's always funny with fellows, those who are involved in the academic side of things. We interviewed our fellows December 19 months ago. We interviewed them. So they were they're in the middle of their third year. Now they've finished their residencies. You never know what you end up with. And plus, you don't remember anybody. Though I have to admit, last time I saw them, we didn't have masks on. So at least for 20 minutes or 30 minutes, we did see them. So we look forward to a great, great crop of fellows. Now, today's talk is on CT evaluation of GIST tumors. Now, I'm giving you a talk, but I'm not giving you any slides. If you go on CTisus, if you look under stomach or small bowel, you'll see many GIST tumors. There are lectures in the small bowel and stomach where parts of it talk about GIST tumors, and perhaps I'll put together a full lecture on GIST tumors. And I think I maybe have already. It's coming out soon. Now, one of the things to remember, GIST tumors stand for gastrointestinal stromal tumors. They're very important tumors, and their frequency has increased by fourfold over the past 30 or 40 years, so we see them much more commonly. GIST tumors, the most common location, 70% are in the stomach, about 20% are small bowel, but they can occur anywhere in the GI tract. They can occur in the esophagus, stomach, small bowel, colon, anal region. They're a great mimicker. When they're small, like in the small bowel, 1 or 2 centimeters, they can be very, very vascular. When they're near the head of the pancreas, they look almost like a neuroendocrine tumor. They can look just like carcinoid tumors, except you don't have a mesenteric mass. When they get larger, they tend to be relatively hypovascular. When they get really large, they tend to ulcerate. Now, I'll talk about GIST tumors of the stomach and GIST tumors of the small bowel. The esophageal ones look like soft tissue masses, typically exophytic. The ones in the rectum, lower colon, almost look like masses pericolonic. But let's just do the stomach and small bowel. So the stomach. GIST tumors can range from 1 centimeter to 20 centimeters. Sometimes they're intraluminal, smooth, 1 to 3 centimeters, incidental finding. Typically, you don't worry about malignancy in GIST tumors, the mitosis per high-powered field, till they're over 5 centimeters. Lesions under 5 cm tend to act benign. So that's a good thing. Now, GIST tumors can be intraluminal, but the classic GIST tumor is extraluminal. So it grows outside of the stomach, can be very large. Typically, they're not very vascular. They can ulcerate when they get larger. Patients can present with bleeding, for example. But they can indeed be very, very large. One of the challenges is, particularly when they're not ulcerating and they're exophytic, it's hard to tell, is it something that's abutting the stomach or arising from the stomach? Maybe it's a pancreatic mass, maybe it's splenic mass, maybe adrenal, maybe retroperitoneal. So it's kind of tricky at times. Once you've seen a lot of them, so go to our teaching file, you see a lot of them. Once you see a lot of them, you kind of recognize them. But that exophytic nature is the key finding to me. When GIST tumors metastasize or recur, they commonly go to the mesentery or omentum, solid masses. It is one of the tumors that goes to the liver as a cystic metastasis. So when I talk about cystic mets, I always mention ovarian cancer. I always mention GIST tumors, which ulcerate, and melanoma. Now, in terms of this, now most of the time when I see GIST tumors, they're along the greater curvature of the stomach, but they could be anywhere. But again, huge masses simply looking like they abut the stomach. Again, coronal views can be very helpful. On the axial views, you sometimes have no idea where things are, so it can be tricky. Now, in the small bowel tumors can have many appearances, and they're great mimickers. So let me just tell you a couple. They often occur in the duodenum. Sometimes they're small, let's say 1 to 3 cm, and they're very vascular. They look identical to carcinoid tumors of the duodenum. And also, when they're medially and exophytic, they kind of often look like neuroendocrine tumors arising from the pancreatic head. Now, it can be tricky, but you got to be thinking about it. The thing that helps me is when I do coronals, and especially when I do 3D volume rendering or cinematic rendering, the lesions for GIST are exophytic, right? They grow outside. Carcinoids are in the wall, so they kind of grow more inside. Again, separating it from the pancreas can be tricky, but again, sliding through on coronal views can be very, very helpful in that regard. We then see other duodenal tumors, larger ones. Typical thing is patients are sent to multidisciplinary conference pancreas with a pancreatic mass. Then I look and I say, oh my God, there's a 5 centimeter mass. It's well-defined, homogeneous, but there's no dilated common duct, there's no dilated pancreatic duct. This is no way an adenocarcinoma. Perhaps sometimes you can say, what about a hypovascular neuroendocrine tumor of the pancreas? That's a thought, but it doesn't really look like this. The epicenter here is duodenum, and so it's a duodenal GIST tumor. Now, fast forward, more distally in the small bowel, particularly jejunum, but also ileum, but jejunum especially. Tumors are often small and vascular, so their presentation can be GI bleeding. One of the things, we do lots of CT for suspected or known GI bleeding, looking for the source, since CT is the gold standard. Often you'll see small vascular tumors. Again, you could say carcinoid versus GIST or metastatic renal cell, but the GIST tumors tend to be exophytic, carcinoids intraluminal. Also, carcinoid tumors typically associated with mesenteric mass and desmoplastic reaction. You don't see that appearance when you're looking at small bowel GIST tumors. So small ones, very vascular, often present with bleeding. Now, as they get larger, the larger ones we see are sometimes ulcerating. Because they grow exophytic, even when they get very large, they don't cause any bowel obstruction, right? Because intraluminal masses obstruct or intussuscept. If something is growing exophytically, it really isn't causing bowel obstruction. And in those cases, the exophytic mass can be confused with other processes, such as lymphoma, maybe a carcinoid tumor, but there's no desmoplastic reaction. These tend to be very smooth. So it's a very important differential diagnosis. GIST tumors of the small bowel can ulcerate, but again, sometimes you're not certain it's really of the small bowel. Sometimes you say, gee, it's a large mass, it's smooth. Maybe it's a mesenteric mass, maybe it's a desmoid, maybe it's a funny carcinoid, maybe it's a small bowel adenocarcinoma, maybe it's metastasis, maybe it's adenopathy, because these GIST tumors abut what seems to be abutting the bowel rather than arising from the bowel. And then you think about something exophytic. So again, you want to be very careful. Things that can be very helpful. One is IV contrast material. Now again, as I mentioned, lots of GISTs are relatively hypovascular when they get larger. Sometimes the use of positive oral contrast can be very helpful. At times you're going to miss small GIST tumors unless they're vascular. But with positive oral contrast, like oral Omnipaque, for example, it's easy to see the lesions. So people like Perry Pickard have written articles about using positive contrast in oncology patients or suspected tumors of the small bowel. So that can be very, very helpful. So I do like that. Now, with the GIST tumors, usually it's a solitary mass, not multiple. As I mentioned, mets to omentum or to liver do occur. Typically, a presentation, we usually see it local. Surgeons will resect the tumors. Sometimes the lesions have lots of vessels when the lesions get large, and I've done a number of cases of cinematic rendering showing the vascular map, and the surgeons do tend to be aggressive. There are certain chemotherapies that are commonly used for GIST tumors. Gleevec is the one that we typically think about. Sometimes with large tumors, patients will get the chemotherapy like Gleevec, and that'll cause the tumor to be necrotic, get smaller, and then surgery will occur. If patients are surgical, the recommendation is to operate and perhaps think about giving chemotherapy after. But the ability to resect the tumor with clear margins becomes very important. There's lots of new markers being developed for GIST tumors. There's work being done, and we need to do some here, but we haven't, with AI looking at GIST tumors, predicting which ones are aggressive, which ones will need chemotherapy. So there's lots of work being done in that regard. Now, in terms of small bowel, if you ask me, let me just go to protocols for a second. I mentioned oral contrast. In general, however, if I'm doing a dedicated small bowel study where I'm looking for a possible mass, or surely I'm looking for a bleed, then we're using water as an oral contrast agent. There's good distension with water, okay? And you can see the enhancement very nicely. You can pick up even small tumors. GIST tumors typically are not multiple, but theoretically can be, so you want to be careful that you're looking at that. But again, you got to be thinking about GIST tumors. Most of the time, I've seen them either missed because people assume they're unapacified bowel, or I see the differential diagnosis being changed. That's Becky Ryan calling me. Becky's our chief tech. I'll just tell her, hey Becky, I'm recording right now, so I can't speak to you. But if you go on CTisus live at about 12 minutes, you'll see me answering the phone. Okay, I'll call you back. Bye. So this is really live because I had to answer the phone because it would have kept ringing. Okay. Anyway, so that's what I think we need to do. Again, in terms of looking at the images, I think particularly small bowel tumors can easily be missed. We know that across the board. Coronal views routinely are very helpful. At times I've seen particularly masses where, again, as I mentioned, they're assumed to be unapacified bowel. When you start looking at the coronals, you recognize exactly what you're looking at. You're looking at what is really there and what needs to be recognized. So again, it'll decrease your miss rate. Now, just in terms of questions, I don't see anybody asking questions. I know one challenge today is I changed times, and everybody knows to come at 12 o'clock. But you'll be if you missed this and you came late, you'll be able to watch it. But if you have any questions, now is a good time for people to ask questions. Now, in terms of differential diagnosis, things that you can be confused with, I mentioned carcinoid tumors. I'll also mention lymphoma can be very bulky. Lymphoma can encase the lumen. Lymphoma typically doesn't obstruct. Lymphoma commonly ulcerates, but small bowel lymphoma often associated with adenopathy, and the infiltration of the bowel tends to be circumferential, and with GIST tumors it tends to be eccentric. So that tends to be a very easy way of looking through things. Now, in terms of protocols, again, the importance of, when you're looking at small bowel tumors, doing dual phase imaging. Again, one of the reasons I could recognize GI bleeding is because we do arterial phase and venous phase, but the arterial phase is particularly important for detecting small bowel tumors that are vascular. Think carcinoid, think small GIST tumor. Venous phase imaging, obviously things like lymphoma, adenocarcinoma all work well, but I think when you use the arterial phase, you can really pick up things better. We picked up what we think might be a 5 millimeter GIST tumor the other week on a patient, only because water distension of the small bowel and then this really bright dot. And I think one of the things you recognize is there probably are lots of patients with small GIST tumors. It's something that's not that uncommon, but we typically don't see those because the patients typically have no symptoms and they're typically not going to cause any problems. So that's my talk on, or my talk without slides on GIST tumors. I recommend you go into the teaching file, look at a bunch of the small bowel cases, look at the gastric cases, take a look at the real spectrum of disease. Again, CTisus teaching file, you can type in under stomach GIST tumors. You'll see hundreds of cases. Same thing in the small bowel. There are a few good articles. If you go to our pearl section, there's tons of pearls. If you go to the section where we show the articles for the month, you could again type in GIST tumors and you'll see a lot of articles. There's been several recent articles in abdominal imaging and in JCAT, and in fact even AJR. So there's lots of good stuff. And one of our folks here, Rocky, is writing an article, and she's going to finish it, she told me. So anyway, so with that, let me thank everybody for their time, and have a great day. Have a great July 1st, and we'll see you next week. Bye.